So welcome everybody. I will be speaking to you on anesthetic considerations for adenotonsillectomy. So this is a very common topic for the diploma and also for the final year exams. So you are expected to know this topic inside and out because you are more likely to encounter a patient that's coming in for a tonsillectomy in private practice or even in the government setting. Most of the time, these patients are pediatric patients, but it's not uncommon as well to get adult patients coming in for tonsillectomies. So the outline of this presentation that we'll have a little bit of a look at the anatomy, the indications for adenotonsillectomy, the pre-op management, intraoperative management, post-op management, and we'll have a little bit of discussion around the bleeding tonsil. So in terms of the anatomy, what I want you to appreciate from this picture is the palatine tonsil, which is what the surgeons will be operating on. And then here you can see the uvula and obviously the tongue. So what are tonsils? Tonsils are a set of lymphoid organs facing into the aerodigestive tract, and they form part of the immune system. There are different types of tonsils. So they are the adenoid tonsils, the lingual tonsils, palatine tonsils, which is what we are mainly focusing on in this presentation, and the tubal tonsils. So these tonsils form what is called Wild-Eyer's tonsillar ring. This is a sagittal view just to show you again where the palatine tonsils are located. So when you go to the wards to perform your pre-op assessment, and those who are trainees in anesthesia, your consultant or staff is going to ask you about the patient's Mallampati score. And when you perform airway examination, it's one of the important components or one of the important things that you need to report upon. However, it's important to note that the Mallampati alone does not determine whether you will have an easy or a difficult intubation. However, patients with a Mallampati of class 3 and higher are more likely to be difficult intubation. So it's important to understand that. And often in the exams, they will ask the Mallampati score, so you need to know what structures can you see when a patient has a class 2 or a class 4 Mallampati score. Then there's what they call the Comac-Lehane grading system, which is what you can see at the bottom here. So this is the Mallampati is what you assess pre-operatively when you ask the patient to open their mouth, and the Comac-Lehane grading system applies at the time of laryngoscopy. So with the grade 1, you're able to see the vocal cords, arytenoids, the epiglottis very well. And at grade 4, you can barely see the epiglottis, and of course, you cannot see the vocal cords. So the next slide just shows you the Comac-Lehane classification, grade 1 to 4. Note that grade 2 is split between A and B, and with grade 4, you can't see the glottis, you can't see the epiglottis, and chances of having a difficult intubation is very high. And in those instances, you will need a video laryngoscope or a fiber optic scope in order to help you intubate this patient. So what are the indications for tonsillectomy? There are many, and I'm not an ENT surgeon. However, I just listed a few here on the slide. So recurrent or chronic tonsillitis, adenotonsillar hyperplasia with obstructive sleep apnea, that's OSA, a malignancy of the tonsils, patients with failure to thrive, abnormal dentofacial growth, and persistent halitosis. So what are the issues when a patient is coming for a tonsillectomy? So the main issues that are there are patient factors, anesthetic factors, and surgical factors. So the concerns as well that we are mainly concerned about in these patients are the fact that the patients have OSA. Quite a number of them that come for this procedure have OSA. That's from the patient's factors, and then surgical factors, the fact that you have got a shared airway. And when we talk about shared airway, we are speaking about uh, how the surgeon and anesthetist are working in the same area. And the issues that arise from a shared airway is that it is difficult from an anesthetic point of view when you've got a shared airway, and it requires a greater level of skill because in some operations, and not specifically with the tonsillectomy, sometimes the surgeon might require the removal of the endotracheal tube in order to inspect the structures surrounding the airway. And at that time, one needs to be vigilant, and the greatest risk is that of losing the airway or soiling of the airway. Hemorrhage is also another important thing that often occurs with tonsillectomies. However, there are more advanced techniques that can obviate this type of complication. And for us, from the anesthetic point of view, our concerns are the apnea that these patients can have post-operatively, the risk of aspiration, which can occur intraoperatively or post-operatively. Pain is a big issue because patients do have a lot of pain after the procedure. And post-operative nausea and vomiting also comes to the fore. Firstly, it can be distressing for the patient. Secondly, from the anesthetic point of view, if patients are going to be nauseous or might even vomit, it might put them at a risk of pulmonary aspiration. And then from the surgical point of view, if a patient is nauseous, they're vomiting, there's a high risk that they might be bleeding at the surgical site, and the surgeons will not be happy if they have to take the patient back to theater because of a rebleeding tonsil. So pre-operatively, when you go and see these patients, you have to perform your standard pre-op visit. You need to ask the relevant questions like you'd ask any other patient coming in for surgery. And you want to find out if they have ever had an anesthetic, were there any complications, did they suffer from post-operative nausea and vomiting, what were the events surrounding their operation, is there a family history of things like malignant hypothermia or other anesthesia-related complications that are idiosyncratic to that particular family or particular condition that the patient might have or might be familial. And in addition to that, you need to obviously do your clinical examination, and you need to pay close attention to features of obstructive sleep apnea and also issues on the history that might point to obstructive sleep apnea. You need to check the blood pressure because often these patients have hypertension. An ECG is indicated. You're looking for features of right ventricular strain or P pulmonale. Patients might have right ventricular hypertrophy or cardiomegaly on chest X-ray. An echo is only indicated if you are suspecting pulmonary hypertension. Assessing the patient's effort tolerance is also important. And pre-meds is something that you would not do for these patients because some of them do have obstructive sleep apnea and they're going to be more sensitive to any pre-medications that you might give them and might put them at the risk of airway compromise. So if you do suspect that the patient has features of obstructive sleep apnea, you want to ask them a series or a batch of questions. And the questionnaire that has been validated is that called the stop bang questionnaire. So stop bang is actually a mnemonic. So S stands for snoring. You want to ask, do you snore loudly? So most people wouldn't know, but their partners might know, and the spouse might know, or their family members might know. And typically, this snoring is quite severe that they can actually hear it in the next room. If someone is sleeping in the next room, they can hear the snoring. Ask them about tiredness. Do they feel tired? Do they feel fatigued, especially during the day? So with sleep apnea, if they've got daytime tiredness and they feel sleepy, they want to sleep during the day, it shows you that this is a severe form and it's called obstructive sleep apnea syndrome. You ask them also if there's been any observed apnea. Of course, they won't be able to know because they are asleep, but their relatives, spouses, or partners might have observed episodes of apnea. High blood pressure, that they definitely will be able to tell you if they've got high blood pressure. If they are not aware of it, you can actually measure the blood pressure, and the nurses in the wards can measure a series of blood pressures, and you might be able actually to diagnose new onset hypertension on their current admission. BMI, body mass index. So they might not know what their BMI is, but you can measure the patient's mass and height and be able to calculate the BMI. Age, they'll be able to tell you how old they are. So if they're older than 50, neck circumference, which you'll need to measure. So the significant value is more than 40 centimeters. And if you're using inches, more than 15.75 inches. And gender or male. So maybe gender might not be the proper word in our present day. Maybe we should say sex being male. So if you're dealing with a male patient, they are at a higher risk of having sleep apnea. So once you have asked them all these questions, if they say yes, you score them a 1. If they say no, you score them 0. So if a patient has a score of 0 to 2, they're at a low risk of having sleep apnea. If they're at 3 to 3 or 4, intermediate risk. Once they have a score of greater than or equal to 5, these patients are at a high risk of having obstructive sleep apnea, and you need to refer the patient for sleep studies. And the sleep study is called a polysomnography. So when they conduct these sleep studies, the patients are monitored in terms of the number of episodes apnea or hypopnea during the night when they're sleeping. The saturations are monitored, and the movement of their limbs are also monitored, and the position that they adopt during sleep is also monitored. And based on these parameters, sleep study doctors or physicians can be able to diagnose patients of obstructive sleep apnea and prescribe the relevant treatment. So there are scoring systems that can help one diagnose also patients with obstructive sleep apnea, and it's called an apnea hypopnea index. So if it's less than 5, which is the number of apnea hypopnea events in an hour, then it's normal. So what is apnea? Apnea is basically cessation of breathing, put simply, and there is no airflow through the nasal cavity in the airways, and typically it's about a couple of seconds, and sometimes can go up to having more than 15 seconds about. And during that phase, the patients are not breathing. And when they begin to desaturate, what then happens is suddenly they wake up because the body begins to, or the brain actually begins to detect that they are not breathing. And this is what the problem is, because it disrupts their sleep and affects their quality of sleep, because from time to time, they have to wake up and start breathing again. And then there's hypopnea. So hypopnea is related to apnea. The difference between hypopnea is that there is some airflow, but there's limited airflow. As opposed to apnea, it's complete cessation of airflow. With hypopnea, there is limited airflow. I think it's about 50% reduction in the airflow as well that occurs at this time. And typically the reason for the apnea, hypopnea, obviously it is central, but also there are issues to do with the loss of airway tone when these patients are actually asleep, that then leads to obstruction of the airway. Then mild, we're looking at about greater than or equal to 5, but less than 15. Moderate, greater than or equal to 15, less than 30. And severe is when patients have more than or equal to 30 events of apnea or hypopnea per hour when they are sleeping. So this is mainly for adults. Children also have apnea, hypopnea index, but the values are different. For the diploma exam, they may not ask you details about this, but it's just important to know that the gold standard for diagnosing obstructive sleep apnea is the polysomnography, which is a sleep study, and also you look at the apnea hypopnea index to assess its severity. So OSA in children also does occur. So you would need to find out from the history if the child has 3 or more episodes of snoring at night, and the parents will be able to tell you if the child does snore at night. And if the child has got labored breathing associated with this snoring, you'd know that definitely this child most likely has got OSA. And the children might have apneic episodes as well, and that might be scary for the patient, for the parents. Parents may also report sleep enuresis, which is bedwetting, cyanosis, which is really bad, and they might also have attention deficit hyperactivity disorder, otherwise known as ADHD. Children may also have daytime sleepiness, and parents may not know about this, but when they go to preschool, the teachers might report that they sleep a lot during their school time, and this might be because of the fact that they have poor sleep during the night, poor sleep quality during the night. Patients may also have learning difficulties and failure to thrive. So on induction, what are you going to do? How are you actually going to anesthetize this patient with coming in for tonsillectomy? So for the pediatric population, it depends. If you've got IV access, you can use IV line for induction. But most of the time, and most of my dealings and in most of my experiences is that these children come to theater without IV access. So your only option is to conduct an inhalational induction. However, there is the inhalational induction, there is a caveat in that, because these patients have got obstructive sleep apnea. Once you induce them with volatile anesthetic, they can actually start obstructing. So you must have a very low threshold to use an oropharyngeal airway, making sure, obviously, before you place it, the patient is adequately deep so that you don't precipitate a laryngospasm. Some positive pressure does help as well when you are inducing them, just to have a little bit of positive pressure, just to help keep the airways open and relieve the obstruction. Obviously, you don't want to give too much, because at the end, air goes to the area of, takes the path of least resistance, and it's going to end up in the stomach, and then you're going to inflate the stomach, and then that's going to cause a whole lot of problems with ventilation, and also you might end up having the patient regurgitating, which you do not want to happen. So always consider the spontaneous ventilation technique in these patients. Once you have managed to establish IV access in a patient you've induced using inhalation and induction, you want to then obviously secure the airway. So in children, what I often do is we topicalize the vocal cords. The reason why we topicalize is that also it helps avoid laryngospasm at the time of extubation. And it also allows you to be able to intubate the children without having to give muscle relaxants and a whole lot of agents. So we topicalize airway, about 2 milligrams per kg of lidocaine or lignocaine. And in adults, you can go up to 9 milligrams per kg. That's up to the toxic dose in adults if you're going to use it for topicalization of the airway. And the tube that we use is a Ringa-de tube because we don't want the tube to kink when the surgeons are operating. You can use a normal type tube, but the problem is it will kink during the procedure. And from time to time, you will have difficulties ventilating, the airway pressures will go up, and you will need to interfere actually with the surgery, because sometimes you will need to tell the surgeon to not to release their pressure on the tube, and they may not be happy because it's going to interfere with their procedure. Throat pack, I like to get insert the throat pack. However, it is controversial in some centers. They are averse to throat pack, so you need to do what is standard in your center. But the reason for using a throat pack is that it tends to mop up blood that might be at the surgical site, and it helps to reduce soiling of the airway due to blood and any other secretions. So you want to maintain the patient on a volatile once you have inserted the tube, and you would proceed with your anesthetic as you would do for any other. So this slide just there to show you the Ringa-de tube, also known as the south-facing tube. And the important thing to know about the Ringa-de tube or the Ray tube is in children is that there is a higher risk of having an endobronchial intubation. So you need to auscultate the chest after you've inserted this tube. Another thing I've also found when using the Ringa-de tube in children is that you might perform your calculation and decide, I'm going to, for example, use a size 5 tube, but when you get to intubating the patient, you might realize that the tube is actually too small and you'll need to use a 5.5 tube. So you need to be quite flexible with these type of tubes. Always have one size above, one size below, because you might be surprised that the tube might be too big or too small. And sometimes it's difficult to tell if the tube is actually the right size. But when the surgeons start operating, if they notice that the tube is beginning to migrate proximally, then definitely that tube is too small. You might have been able to intubate, but if the tube is migrating proximally and they can see the cuff, or they can see the demarcation lines of the tube, and this tube doesn't have it, but you see this black line proximal to the surgical site, it's likely that the tube has migrated and the tube you have chosen is too small. And at that time, it's important to speak to the surgeons and request them to change the tube. They can actually do it for you. Another telltale sign that the tube is too small is if the surgeon notices that there are bubbles or there's bubbling at the surgical site, and that's because there's a leak, because the tube has migrated. So be always open to speak to the surgeon, have a good relationship with the surgeon, talk to them, ask them to replace the tube, because when they're already when they've already put in the mouth gag, they are able to see the vocal cords and they can easily just replace the tube and put it in for you actually, and proceed with the surgery. But to try and proceed with the surgery, hoping that everything's going to be fine, you will just make things work, is actually risky, because The problem is this might lead to soiling of the airway. The other issue is you may not be able to ventilate the patient adequately. You administer inadequate tidal volumes, patient might become hypoxic, and if they're not hypoxic, they can also become hypercarbic. And then eventually when the surgery is over, you're going to sit with the patient with high CO2s because you couldn't give enough, you could not supply enough or adequate tidal volumes, and now you need to hyperventilate the patient to blow off the CO2, and then it's going to cause CO2 narcosis because of the accumulation of CO2. It's going to delay actually emergence, and obviously the surgical team is not going to be happy. So I always recommend changing that tube if you are not happy. And then another important thing as well is that when you secure the tube, always make sure that you put either a small piece of gauze there, apply your tape. This avoids pressure necrosis on the lower lip, and also it will help keep your tube in place so that it doesn't come out. So you put a piece of gauze there, place a tegaderm on top of that, directly on the skin, and another tape on top of the tube so that the tube remains secure and also the patient remains safe. So this is the ultimate position the patient will be in with the Boyle-Davis gag in situ. And you can kind of see why I was talking about all those issues around securing the tube and using a ray tube. Is because once the mouth gag is in place, it actually pushes against the tube. And if it's an ordinary tube, it is going to kink. But if you have to use an ordinary tube, how can you work around this? So what are you going to do? You might consider moving the tube to the lateral aspect, maybe to the left lateral aspect, and hoping that your ventilator is on this side so that you can easily access your tube. And you may consider putting a piece of gauze so that there isn't obstruction of the tube. And maybe speak to your surgeon to not apply as much pressure on the Boyle-Davis gag to avoid kinking it. But it's very difficult to use an ordinary tube. It just makes the surgery longer, more difficult, and just complicates the anesthetic. So analgesia is a big thing. Pain is a big thing with this patient. So the magic word I always say is multimodal opioid-sparing analgesia. You can give NSAIDs, and as long as there is no bleeding, and I like to speak to my surgeon if they're worried about bleeding at the site. So if it's a repeat or a redo procedure, obviously bleeding is going to be an issue. But most of the time, NSAIDs are safe, and they will not increase the risk of bleeding. So you can give diclofenac suppositories in children, but you must have spoken to the mother or the father or parent that you intend on putting these suppositories into the patient's rectally. Paracetamol, acetaminophen, and those in the North America, Tylenol. IV, you can load the patients with 20 milligrams per kg, and then subsequent doses 15 milligrams per kg. Fentanyl, 0.5 to 1 mics per kg. Morphine, 0.1 milligram per kg. And if patients have got established OSA, I would recommend reducing that or halving the dose to 0.05 milligrams per kg. Clonidine, which is an alpha-2 agonist, can be given orally prior to the procedure or can be given IV, and the dose is the same. It's 1 milligram per kg. Precedex, which is dexmedetomidine, the dose is similar. It's 1 microgram per kg, I must correct. So clonidine, 1 microgram per kg, and also Precedex, 1 microgram per kg. Dexamethasone also can be given 0.15 to 0.25 milligrams per kg. It will also help with post-operative nausea and vomiting. And when it comes to analgesia in any anesthetic procedure, timing is what I've found is the most important thing. So timing is of utmost importance. If you give analgesia at the wrong time or give it too late, then the patient is going to wake up in a lot of pain. Then there are some analgesics. If you give them too late as well, you will get analgesic benefits, but they will prolong your anesthetic or prolong your emergence or delay your emergence. So timing is very important. The second thing as well with getting on top of your analgesia or getting on top of pain is the dosing. So if you get the dosing wrong, patient is going to have pain. So it's a balance. It's a balance of timing. It's a balance of dosage. And it's also a balance of understanding your particular patient and tailoring the anesthetic to the patient. So just looking at the drugs that I've listed here, how would I give them in terms of timing and dosing for a patient who's coming in for a tonsillectomy? Let's say the intention is for the patient to be discharged home. So I have done tonsillectomies on a daycare basis where patients actually went home after the procedure. So your aim is, if you want the patient to be discharged on the same day, you want to reduce your opioid administration, because opioids will cause delayed emergence, and also opioids can cause apnea, and also they are associated with post-operative nausea and vomiting. So you want to reduce your opioid intake. But if you have to give them, you want to give them early. So straight after induction, I would want to give my short-acting opioids and my long-acting opioids. So short-acting opioids like fentanyl, you want to give those early. Morphine, you want to give those early. The reason why you want to give them early is because their onset is their analgesic benefit. Like, for example, morphine will only be up after 30 minutes. Fentanyl will be much sooner, maybe 3 minutes. Fentanyl, 30 seconds. But with morphine, because it only kicks in much later, the analgesic dose is so that by the time the operation ends, you are getting more of the analgesic dose than the respiratory depressive effects of the drug and any other complications associated with the drug. So you want to give it early so that you can be able to have adequate and good analgesia at the end of the procedure, and also later on when the patient actually goes to the ward. What about acetaminophen or Tylenol? That you also want to give early. The advantage is if you give it early, you can repeat the dose as well before the patient actually goes home. So if you give Tylenol, IV Tylenol, IV paracetamol early, the patient can get it also within 4 hours from the time the first dose that it was given. That helps you as well to get on top of the pain. What about clonidine and Precedex? These are wonderful drugs. They're alpha-2 agonists. You can't give them alone. The advantage of these two drugs is that, and obviously you're going to give one or the other, not both of them, because both are alpha-2 agonists. The advantage of these drugs is that they will help with emergence delirium, and they are also analgesic. They've also got an analgesic effect. Just like morphine, you want to give them early because if you give them later on, they will cause delayed emergence. The advantage, though, of alpha-2 agonists is that they do not have respiratory depressive effects. So if you want to actually reduce your dose of morphine, you can give more of the clonidine to get more of an analgesic effect and less respiratory depressive effects from the opioids. That will help you obviate respiratory depressive effects from the opioids. And dexamethasone, obviously, its effects are not going to be appreciated in the intraoperative period, but more in the post-operative period, because these are steroids. They'll reduce the swelling and reduce inflammation. And by the patient will mainly benefit from the effect of using these steroids in the post-operative period. So I just thought to spend a little bit of time on analgesia because it's quite tricky, and I've seen many anesthetists struggling with this so-called tonsillectomy recipe, especially if the surgeon desires to discharge the patient on the same day. So it becomes quite tricky. Either they give too much and the patient wakes up very sedated, and it takes long for them to recover, but they are well analgesed, or they give too little, patient wakes up well, but is crying of pain. So it can be tricky. The other medication that one can possibly think of giving is ketamine. However, the problem with ketamine is that it can cause uh, the release of secretions, and you can have a lot of secretions post-op, and that can be distressing for the patient. But it is analgesic, and it can also help you reduce the opioid requirements. Post-operative nausea and vomiting is important, so we use ondansetron 0.1 to 0.15 milligrams per kg in our practice, and the dexamethasone as well that I did mention, and you would use the same dose that I mentioned in the analgesic part. So if you've given it for analgesia, you don't have to give it again for post-operative nausea and vomiting. It can play the role, those two roles that you will be able to benefit from the analgesic effects and the anti-nausea effects as well. On emergence, it's important to suction the patient under vision, and when I mean under vision is you must use a laryngoscope to inspect the area around the tube. If you put in a throat pack, it's important to remove it, and the theater staff and anesthetic nurse as well must record that the throat pack has been removed, and you must speak to your surgeon and tell them, also communicate to them, tell them the throat pack has been removed and clots have been suctioned from the airway. It's important also to inspect behind the uvula, because sometimes there may be a clot there, and clots that are maybe occult, clots that then once you take out the tube might potentially fall into the airway. And this clot is called the coroner's clot, which can then cause collapse of one of the bronchi, and then make it very difficult to ventilate the patient. So it's important to make sure that you suction under vision. And the positioning is also important as well. So they talk of the tonsillar position, which in some journals talk of putting the patient in the left lateral, head down position, suctioning the patient. Some airway anesthesiologists I've worked with do not like the tonsillar position. They prefer to extubate the patient in the sitting position, the argument being that they make use of gravity. And when a patient is sitting up, all the clots will move downwards due to gravity, and it's easier to pick them up and to suction them and see them. So the most important thing, I wouldn't say which position is superior, the tonsillar position or the sitting position. I don't have evidence. I haven't come across a paper which says which position is the best after a tonsillectomy at the time of extubation. But the most important thing is to always suction under vision and make sure that there are no clots in the airway and that there is no bleeding at the surgical site. Then the next question that then one raises is, at the time of extubation, should you extubate these patients deep or should you extubate them fully awake? So I prefer to extubate the patients deep. My reason is that I don't want the patient to cough, and also the surgical team is very happy if the patient is not coughing at the end, because excessive coughing can lead to bleeding at the site, because the coughing can aggravate bleeding. So you don't want that, and the surgeons don't want that. They prefer for a deep extubation. However, to extubate the patient deep requires a certain level of skill and practice. So people who are not au fait with this method, I would not suggest trying it out, because you may potentially lose the airway if you are not skilled at deep extubation. So most people prefer to extubate the patients fully awake in the tonsillar position. The important thing then is to continuously monitor the patient so that the patient doesn't start gagging on the tube or coughing. So once you notice that the patient is ready to be extubated, you've gone through all your extubation criteria, what I would recommend is actually speaking to the patient and calming the patient down and telling the patient that you're about to take the tube out. They must not cough, they must not fight, and they must open their mouth, and you suction, apply some positive pressure, and then take the tube out. And this is a better method because the patient is going to be awake and cooperative, and they are less likely to cough. And this method is much better for people who are not as skilled at this at deep extubation, and it's safer then, and it avoids precipitating a laryngospasm or a bronchospasm at the time of extubation. Another thing that often happens at the time of emergence is delirium. So delirium occurs quite a lot with children after tonsillectomy. And what it is that these patients have an altered state of consciousness, typically occurs after an inhalational anesthetic, and the anesthetic has been stopped like 15 minutes. This normally happens after 15 minutes of cessation of the anesthesia. And what happens with these patients is that they are not aware of their surroundings. They may thrash around, they may kick things, they may pull out lines, they might even pull out the catheter, they've got a catheter, and they may also potentially injure themselves. So it's important to make sure that there's somebody to watch the patient, nursing staff or a parent to be on close by to monitor the patient. And the delirium may resolve on its own. However, because it can cause a lot of concern with the caregivers and the recovery room staff. And also patient may potentially injure themselves in the process. So we like to use pharmacological interventions. So you can use ketamine, low dose ketamine at 10 to 25 milligrams per kg. At this dose is a very low dose. You will not get hallucinations, and you will not get excessive secretions, and the patient will calm down. However, ketamine is not the drug of choice that I would go for. I would rather go for dexmedetomidine, and I've used it successfully in patients who've had this post-op delirium after tonsillectomy. I wouldn't use the 1 mic per kg that I mentioned for analgesia and in intra-op. I would opt to use a lower dose, and I would use 0.5 mics per kg. And obviously, you remember that dexmedetomidine can cause a bradycardia. So you want to give it slowly. It works very well. Patient will calm down and they'll actually sleep. And also, the advantage of alpha-2 agonists is that they also have an analgesic effect. So if there is ongoing pain, maybe the pain was not well controlled, the pain experience of the patient will improve. You can also consider using a low dose of propofol. However, you would need to watch the patient because you can potentially lose the airway, or the patient can potentially become apneic. But propofol can also be used for post-op delirium. I have used it. It's not my favorite drug for managing post-op delirium because sometimes what happens is for that short period, the patient will sleep, but then after a little bit of a while, they wake up again and have another phase again of delirium. But the alpha-2 agonists seem to work quite well, and patients settle quite nicely. So in literature, they've also mentioned the use of dexamethasone. I don't think dexamethasone is going to treat the episode of delirium immediately in the post-op phase. But if you have given it intra-op, literature does show that it can reduce the chances of post-op delirium. Another drug that also has been mentioned is magnesium sulfate. If it's used in intra-op, can reduce the incidence of emergence delirium. So post-op, as I said, patient is in the tonsillar position, they're in recovery. You'd want them awake, and then you want to obviously assess for bleeding. So the recovery staff must assess for bleeding from the oral cavity. Sometimes they can have epistaxis, and I've seen with some surgeons, patients after tonsillectomy having epistaxis. So you just need to watch for that. Obviously, it's important to monitor for the patient's vitals. Remember, in the pediatric population, blood pressure is not always helpful because children are flow dependent and not pressure dependent. But however, you can look at parameters such as heart rate, the saturation, and the plethysmograph tracing. You want to also make sure that your patient is adequately analgesed, and I wouldn't recommend using opioids in these patients as rescue analgesia because some of them have got OSA. They are quite sensitive to opioids, and they can actually end up being apneic. So I would advise using non-steroidals if there's no bleeding or worry about bleeding, using Tylenol or paracetamol. Consider giving oral alpha-2 agonists like clonidine because it is available orally. If you've got it in your country or in your hospital, it is available as a tablet orally. And always remember to keep the IV line in situ. Don't take it out because sometimes these patients can bleed from the site and then they come back to theater as a bleeding tonsil, and you will need IV access at that point. And you need to make sure that this line is well secured, that the child, if it's a child you're dealing with, doesn't actually pull it out. So what about the bleeding tonsil? So if a patient has had successful tonsillectomy, but later on they come back as a bleeding tonsil. And sometimes what happens with these patients, they get excessive swallowing post-op, which is an indication that they actually are bleeding from the tonsillar bed. So these patients, you need to treat them as an emergency. They need to be checked pre-op in terms of their hemodynamic status. They might actually come to theater hemodynamically unstable. So if it's a child, you might find the capillary flow is prolonged. They look dusky. They may have poor capillary perfusion, and they may just look lethargic. So these patients, you need to then check what their hemoglobin is. And it's advisable to do an arterial blood gas so you can be able to know how well the patient is ventilating, oxygenating, and their acid-base status and their hematocrit. That will then guide you as to how you will perform your anesthetic and what resuscitative measures you need to take. The patients are at a risk of aspiration because they have been swallowing blood. So you need to be aware of that. If you are dealing with an adult patient, you can do a rapid sequence induction, but remember, if it's a pediatric patient, it's difficult to do a rapid sequence induction. You would need to do what is called a controlled sequence induction. If the patient doesn't have an IV line, you would do a gas induction with the head up, and once the patient's asleep, then get IV access. If the patient already has IV access, I'll still advise keeping the head up to avoid aspiration. Induce the patient with using a cardiac stable technique. Use etomidate and paralyze the patient with rocuronium at a rapid sequence induction dose. And once we're performing controlled sequence in the pediatric population, you need to watch the saturation, prepared to bag the patient lightly, not to bag excessively, as to avoid inflating the stomach and then leading to regurgitation of blood and stomach contents, leading to increasing the risk of aspiration. You don't want that. The other thing you need to consider is that this is a recurrent anesthesia, so you need to look from the previous anesthetic notes what the patient had. You may need to reduce opioid doses if the patient had opioids quite recently. And the other thing that you also need to consider is that this patient's most experienced person should help you with this patient. And I would have a very low threshold for using a video laryngoscope because you want to get the tube in on your first attempt. These patients are often anemic. If they've bled out, might have an anemic hypoxia. So you will need blood and theater, and you want to have 2 suctions available. So if one gets clogged with blood clots, you've got another one. And patients might be coagulopathic, so a point of care thromboelastography test might be something that you may need to consider. The airway, obviously, risk of laryngospasm, risk of bronchospasm, you need to be aware of that. And obviously, you need to have a tube in there. You need an endotracheal tube to secure the airway, and the surgeon can then proceed with the procedure. After the procedure, you will not send the patient to the ward. You need to send the patient to a high dependency unit. If you are able to extubate the patient, again, you would extubate. In this case, I would not extubate the patient deep. This patient, I would, because of the risk of aspiration, I would intubate the patient awake. So you want to extubate rather, extubate the patient awake, not deep. So you want to extubate the patient awake. And as I mentioned, if you're not extubating, transfer to ICU. If you've got a ring a day airway tube in situ and you want to take the patient to the high care, the ICU or the ITU staff cannot care for the patient properly or adequately. If the patient has got a ring a day airway tube, they won't be able to ventilate well or suction the patient well through a ring a day airway tube. You would have to take that tube out and put in a normal tube so that they can be able to suction down the tube and ventilate the patient with greater ease. So that's basically the end. That is anesthesia for adenotonsillectomy. If you've got any questions, feel free to post your comments below. And thank you very much.